Assalamualaikum warahmatullahi wabarakatuh. Welcome back to the channel Stand Medical Notes or Lectures. So we were discussing about the chronic complications of type 2 diabetes mellitus. So let's discuss the topic of diabetic nerve disease or diabetic neuropathy. So previously we covered two chronic complications. One is diabetic kidney disease and diabetic eye disease. Let's begin with the name of Almighty. So diabetic neuropathy. What's the core clinical definition? Diabetic neuropathy is a heterogeneous collection of clinical and subclinical syndromes causing somatic and or autonomic peripheral nerve dysfunction. Heterogeneous collection of clinical and subclinical syndromes causing somatic nerve dysfunction or autonomic nerve dysfunction. And one important point to remember is it is a diagnosis of exclusion. That's right, requiring the systematic elimination of other metabolic, toxic, infectious, and compressive etiologies. It's a diagnosis of exclusion. So, why should we study this diabetic neuropathy? Neuropathy is the most common chronic complication of diabetes mellitus, affecting 60 to 70% of diabetic individuals globally. Up to 50% of peripheral neuropathies are completely asymptomatic. This leads to silent loss of protective sensation, also known as LOPS, exposing patients to unperceived trauma, chronic foot ulceration, and a seven times increased risk of amputation. It is the direct cause of approximately 60% of non-traumatic lower extremity amputations. The visceral autonomic variants dramatically increase cardiovascular mortality, predispose patients to sudden cardiac death, and severely impair the quality of life. So that's why we should study this. 60 to 70% of the patients will have this neuropathy, and 50% of them are totally asymptomatic. And if they are having this, they are having 7 times increased risk of amputation. Okay, that's how we should study this. So early recognition, regular screening, and prevention of nerve damage are important to prevent disability and save lives. Think of diabetic neuropathy as a silent epidemic within diabetes. Early detection and management make the difference between independence and disability. Coming to etiology and pathophysiology. The development of diabetic neuropathy stems from chronic exposure of vulnerable neural tissue to systemic hyperglycemia, triggering a cascade of metabolic, vascular, and inflammatory pathways. So we well know these three pathways, they come at every point of complications. There is polyol pathway, also sorbitol pathway, advanced glycation products, and protein kinase C pathway. So one more pathway is hexosamine pathway. All these what will do, they will cause vasa nervorum thrombosis. What is vasa nervorum? The blood vessels which supply the nerves. Get thrombosed. So microthrombosis of those blood vessels causes neural hypoxia and ischemia. Okay, that will lead to axonal degeneration, demyelination, loss of myelin sheath, impaired axonal transport, glial cell activation, and neuroinflammation. Okay, and mitochondrial dysfunction. Then you will get a set of, now it is like sensory loss, painful neuropathy, motor weakness, autonomic dysfunction, foot ulcers, and amputation risk. That was in short about diabetic neuropathy pathology. Now coming to somewhat detail. So chronic hyperglycemia triggers multiple metabolic and vascular pathways that injure nerves and their blood supply, leading to neuropathy. Number one is intracellular hyperglycemia and reactive oxygen species generation. So this is well known. Okay. Second is polyol pathway activation. Third is advanced glycation product accumulation, protein kinase C activation. So then vasa nervorum microvascular occlusion. Then the death of Schwann cells and exons. So what is happening here? what is happening in short, we can say here. So nerve fibers, there is damage to axons and myelin sheath. Blood vessels get blocked. Schwann cells get swollen because of this accumulation of sorbitol. Mitochondria will fail because of generation of reactive oxygen species. Okay, so all this will lead to death of these neurons. Okay, and that will lead to sensory loss or motor weakness, painful neuropathy, autonomic dysfunction, foot ulceration. So diabetic neuropathy is not due to single cause, but a combination of metabolic toxicity, oxidative stress, and microvascular injury that damage nerves and their blood supply over time. So antioxidants should be prescribed. Okay, and mostly we have seen that these individuals who develop this diabetic nerve disease, they concomitantly they have this diabetic eye disease and diabetic DED and DPD, diabetic kidney disease also. Okay. Now, classification very important, and severity of this diabetic nerve disease or diabetic neuropathy. So you can classify it as somatic and visceral. In somatic, there are three types. The most common is the DSPN, distal symmetric polyneuropathy. Then mononeuropathy. Then radiculopathy or polyradiculopathy, also known as diabetic neuropathy. Okay, DSPN, distal symmetric polyneuropathy, compression mononeuropathy, and radiculopathy or polyradiculopathy, also known as diabetic neuropathy. Visceral, we have autonomic neuropathy. Now we will see one by one. So diabetic neuropathies are classified into somatic, sensory. In somatic, we have sensory and motor and visceral categories. Severity and clinical progression can be varied using structured classification system. So one is DSPY. So what are the fibers which are involved? Small C fibers, large myelinated A fibers, or mixed. Okay. So distribution, distal glove and stocking, incision onset. So like this type of distribution you will see. This type overlimb. Okay, loss of sensation. So there will be loss of sensation, or there can be burning or lancinating, electric shock like pain, paresthesia, abnormal sensation, diminished vibration, okay, and lost ankle reflexes. In DSPN, it is the most common type of neuropathy. Mononeuropathy, so important to remember, cranial loss of the eyes. So third nerve palsy or sixth nerve palsy. Okay, third nerve palsy or sixth nerve palsy are the most common type. The third nerve supplies all the muscles except the fourth muscle and the except the superior oblique and lateral rectus muscles. All of the muscles, ocular muscles, are supplied by third. That's why when there is third nerve palsy, there is drooping of that eyelid and the eyeball will be rotated. Eyeball will be rotated, but there will be pupil will be reactive. Okay. When there is sixth nerve palsy, so lateral rectus ocular muscle will be affected, and the eyeball will be deviated to the opposite direction. So that is very important to remember. Okay, mononeuropathy. So peripheral nerve, so median nerve involvement, like carpal tunnel syndrome, ulnar nerve involvement. Okay, ulnar nerve involvement. So ulnar nerve involvement. If there is ulnar nerve involvement, what will happen? Okay, what will happen? Ulnar nerve supplies. What do you call? Lateral one third of the hand. So this part of the hand will be affected because medial 2/3 of the hand is supplied by the median nerve. So in the carpal tunnel syndrome, you will have burning sensation in the medial 2/3, whereas when ulnar nerve is affected, you will have burning sensation in this lateral 1/3. And in peroneal nerve compression. Okay, so peroneal nerve compression, you will have problems. You will have tarsal tunnel syndrome, something called as tarsal tunnel syndrome also you can have. So when peroneal nerve is affected, so you will have that type of distribution in the foot. Okay, these are the mononeuropathies. So median nerve can be affected, ulnar nerve can be affected, and peroneal nerve can be affected, and ocular nerves, most commonly third nerve and sixth nerve, can be affected. So these are the mononeuropathy syndromes. They are often unilateral and acute in onset, unlike DSPN. DSPN is bilateral. Okay, DSPN is bilateral and it is insidious in onset. DSPN. So what symptoms will have? So or signs: pupil spared third nerve palsy, meaning pupil will be reactive to light, but there are features of third nerve palsy: drooping of eyelid and what do you call weakness in the ocular muscles except superior oblique and lateral muscles. Acute foot drop can occur because of involvement of peroneal nerve, acute foot drop, and carpal tunnel syndrome. Carpal tunnel syndrome in the hand, upper limb. Okay, these things can happen. So coming radiculopathy and polyradiculopathy, diabetic amyotrophy. So there is the lumbosacral plexus can be affected, femoral nerve can be affected, or thoracic roots can be affected. So when lumbosacral plexus is affected, then the lower limb will be affected, and predominantly the thigh part will be affected. Okay, femoral nerve, when it is affected, it will affect lower limb. Thoracic roots, when they are affected, the patient will have symptoms in the thoracic cage. Okay, so how they present this diabetic amyotrophy or radiculopathy, polyradiculopathy? They'll be asymmetric. Remember again same. Okay, asymmetric proximal leg or trunk involvement. Asymmetric proximal leg or trunk involvement, very important. Proximal leg or trunk involvement, and it can be acute either or gradual. So see here there is in thigh involvement here. So typically like this, or patient will complain of pain in the thoracic cage. So first we will rule out by ECG any MI or something like that is there, or some GI causes of pain. Then we will go to neural causes. There we can see a unilateral neuropathic type of pain the patient will experience in the thoracic cage. Okay, so symptoms and signs: severe thigh involvement or hip pain will be there. Okay, thigh pain or hip pain because of lumbosacral plexus. Rapid quadriceps wasting can occur because of involvement of femoral nerve. Lost knee reflex again because of the same, and profound weight loss patient can have because of amyotrophy, because of wasting. So these are the three important types of somatic neuropathy patient, and the patient will present like this. So in visceral, patient will have autonomic neuropathy. Autonomic meaning you should have in your mind heart, stomach, urinary bladder and penis. Urinary bladder and penis. So sympathetic and parasympathetic autonomic fibers are involved. Systemic organ systems are affected and they are gradual onset. Heart, stomach, urinary genitourinary system. Heart, stomach, genitourinary system. The symptoms will be there. So orthostatic hypotension, resting tachycardia, very important. Resting tachycardia, gastroparesis. Okay, atonic bladder, erectile dysfunction. So these are all the things patient can experience. So this is heart, this is stomach, and this is genitourinary system. Okay, that's about the somatic and visceral neuropathy. So if I want to remember these things, no, I will just imagine a diagram in my mind. So I will just draw and show you. So that will become easy to remember. So just imagine a human like this. A human, okay. He has eyes. Okay. Rough diagram. I am showing. Rough diagram. It is a rough diagram. Rough diagram. Okay. Thighs and then foot. Rough diagram. Okay. So if this is the heart. Okay. This is the stomach. This is the stomach. And this is the urinary bladder, and this is the penis, and This is a thoracic cage. You can take like this. Just it is a rough diagram. Just imagine like that. So how you can remember? So eyes can get affected. Okay, third nerve palsy and fourth nerve palsy. Then here median nerve can get affected, or ulnar nerve can get affected. Then DSPN. Okay, both hands and feet get affected, the most common cause. And you can take thighs, okay, for diabetic hematrophy or radiculopathy or polyradiculopathy, or involvement of the thoracic cage, okay, or foot drop can occur. Then coming to autonomic neuropathies, so heart can get affected, resting tachycardia, orthostatic hypertension, gastroparesis because of your stomach, and atonic bladder and erectile dysfunction. So these all can occur like this. Okay. Now severity staging. So there is one more thing we should remember in neuropathy, that is Charcot Neuroarthropathy. So bone disease, diabetic bone disease. Okay, so that also we should remember. So we will stage the severity according to, so we are now staging Charcot arthropathy, neuroarthropathy. So it is, which is also a component of diabetic neuropathy. So what are the stages of Charcot neuroarthropathy? Charcot neuroarthropathy. Stage 1 is developmental stage. The foot is warm, erythematous and highly edematous. Okay, so this is the pathology. There will be inflammation, hypervascularity and osteoclast activation. So bone demineralization will occur. So what is the management at this stage? Immediate total offloading and immobilization of the leg is the management. Then comes the second stage, that is coalescence stage. Edema and warmth subside. Fractures, I think fractures will also occur here in this first stage only. Okay, now the fractures begin healing and there will be joint fusion. So pathology, there will be consolidation, fusion of bone fragments. Fractured fragments will get fused. So continued immobilization, this is the management, and transition to protected weight bearing. The third stage will become reconstruction stage. Okay, where there is structural deformity is fixed now and foot is cool and stable. Now the management is transition to custom molded therapeutic footwear. Fourth stage is ulceration stage. Ulceration develops over prominent bony deformities. So severe plantar rocker bottom deformity with pressure necrosis, like this. The leg will lose the arches. So here the management is wound care, offloading and surgical evaluation. Okay, so these are the four stages. Developmental stage, so this can be confused with osteomyelitis. Then and fractures can also occur here. Sorry, not osteomyelitis. This can be confused with cellulitis. This should be differentiated from cellulitis. And this is the coalescence stage. So fractures begin to heal, but deformity has not occurred still. Here the deformity will occur, and then there will be ulceration because of exposure of the prominences, bony prominences. Okay, and the management as discussed. Okay, that's about the severity of Charcot neuroarthropathy. Now, when there is ulceration, then there will be infection. So, now coming to the grading of infection severity according to IDSA. Grade 1 is uninfected. There will be no clinical symptoms and signs of active infection. Intact skin will be there, skin will be clean and clear. Routine wound care should be done, and avoid empiric antibiotic therapy. Then comes the grade 2, mild. Okay, grade 2, mild. Local infection involving only skin and subcutaneous tissue. There will be erythema about 0.5 to 2 centimeter around the ulcer. Okay, 0.5 to 2 centimeter around the ulcer. Superficially localized cellulitis, that is mild. Oral narrow spectrum antibiotics targeting staphylococci and streptococci should be given for 5 days, 5 to 7 days. Okay, then moderate erythema will go more than 2 centimeter, or infection involving structures deeper than skin, example abscess. Okay, osteomyelitis, or involvement of joints, that is septic arthritis, like this. Deep tissue, here it was superficial, here it will become deep. So there can be abscess, there can be involvement of bone in the form of osteomyelitis or septic arthritis. Broad spectrum antibiotics, either oral or IV, depending on the condition of the patient, should be given. Consider hospitalization and surgical debridement. Okay. Fourth is severe stage. There is local infection with signs of systemic inflammatory response syndrome, that is fever, tachycardia, tachypnea, and leukocytosis. So sometime like this, the food will be like this. So life or limb-threatening systemic sepsis will occur. There should be urgent hospitalization. IV broad spectrum antibiotics should be given, and emergency surgical intervention should be done. Okay, so that's about the your foot. So first there will be neuropathy, okay, and there will be development of neuroarthropathy, and then there will be ulcer, and then there will be infection. So this will be the chronology. Okay, now coming to the clinical features of this diabetic neuropathy. So you can divide it as sensory, okay, motor, and autonomic, same. Okay, now coming one by one. In sensory neuropathy, patient will have either pain in the foot, okay, numbness, and because of loss of proprioception, poor balance, and loss of deep tendon reflexes, particularly the your knee jerk and the ankle jerk. Okay, so burning, shooting, electric shock like pain, and allodynia, severe pain from light touch or bedclothes patient will have. Large fiber dysfunction, loss of vibration perception, decreased joint position sense, causing trips, falls, and a wide based gait, and lost deep tendon reflexes. First ankle, then knee. First ankle, then knee. Motor atrophy. So atrophy of the small intrinsic muscles of the foot disturbs the flexor extensor balance, causing clawing of the toes and prominent metatarsal heads. This shifts the patient's gait, concentrating pressure on the metatarsal heads and heel, leading to thick calluses. Okay, so clawed toes because of wasting of intrinsic muscles of the foot and exposure of metatarsal heads and heel. So here at these points, these are the metatarsal heads and this is the heel. Then there will be development of calluses, meaning thickening of the skin at these points. But this is not good. What happens? There will be micro cracking of these thick calluses, and bacteria will enter through this, and that will cause infection of the foot. So that's why calluses should be taken care of. They should be removed properly. Then autonomic, if we discuss, okay, autonomic, if we discuss, there will be warm, dry skin with distended veins due to sympathetic denervation induced AV shunting. Pseudomotor dysfunction leads to anhidrosis and dry skin, creating fissures that serve as entry points for infection, as I said. So there will be warm and dry skin, distended veins, okay, and dry skin with fissures will be there. So these fissures will act as portal of entry for infection in the foot. What should we not miss in patients with neuropathy? We should not miss, number one is acute Charcot Neuroarthropathy. So presentation is an acutely red hot swollen and edematous foot or ankle in a patient with that dense neuropathy, often mimicking cellulitis or gout. Okay. Key action: immediate absolute offloading is required to prevent joint destruction and a permanent rocker bottom deformity. That is one thing. Another thing we should not miss is deep plantar abscess and osteomyelitis. A painless plantar ulcer, often hidden beneath a callus. A painless plantar ulcer, often hidden beneath a callus, is the presentation. Okay. Key sign is a positive probe to bone test. Very important. This is probe to bone test. So palpating hard bone with a sterile metal probe has a high positive predictive value for osteomyelitis. The probe to bone test is an important test to suspect, to have a high suspect index of suspension for osteomyelitis. So probe to bone test, if you feel bony by this probe, so then that is positive. Okay, we should not miss plantar, any plantar abscess and osteomyelitis if the patient is having ulcer. And in a patient who has red swollen foot, we should not miss arthropathy, because usually it is perceived as cellulitis or something else. Okay, then diabetic amyotrophy or neuropathic amyotrophy mean nothing but wasting of the muscles. Presentation is acute severe asymmetric pain in the either the thigh or the hip, followed by rapid wasting of the quadriceps muscle, lost knee reflex, and significant weight loss. So this will be the presentation. This must be differentiated from spinal cord, cauda equina, or neoplastic compressive lesions of the spinal cord. Okay, so patient will have they will have weight loss. First, initially they will have a severe knee and thigh pain, then there will be wasting of quadriceps muscle, losing of your knee reflex, and losing the body weight. So that is the presentation of diabetic amyotrophy. We should not miss diabetic amyotrophy. Very important, we should not miss. We should not miss diabetic neuroarthropathy. We should not miss diabetic amyotrophy. We should not miss diabetic osteomyelitis. Then in autonomic, we should not miss silent myocardial ischemia. Painless myocardial infarction in patients with cardiovascular autonomicopathy is the presentation. So they will present only with sweating, no pain. Patient will have only sweating. That's why whenever a patient with long-standing diabetes is presenting you with only sweating, no tachycardia, will not, because these patients will also have this hypoglycemia unawareness. Okay, so suspect MI also in these patients, because because of autonomic neuropathy they will not have any pain. Okay, so if GRBS, meaning if even though if you are having GRBS low also, then also we should do ECG in these patients. Only they will have sweating. Okay, so that sweating you should suspect MI. Okay, even if the GRBS is low. Unexplained acute dyspnea, sudden diaphoresis, sweating, or new onset congestive heart failure in a diabetic patient, always suspect MI. So three things: unexplained acute dyspnea, okay, sudden onset of sweating, okay, new onset of congestive heart failure. So breathlessness and sweating, you should suspect dyspnea, diaphoresis, heart failure, suspect MI in these patients. So we should not miss these 4 diagnoses in patients with diabetic neuropathy. So in food, we should not miss Charcot arthropathy. We should not miss osteomyelitis if the patient has ulcer. Amyotrophy we should not miss, and we should not miss in autonomicopathy a silent MI occurring in these patients. Okay. Then what is the differential diagnosis in these patients? So this is the differential diagnosis. Diabetic neuropathy is diagnosed only after systematically ruling out other treatable causes of neuropathy. So in general, so this is the DSPN. Okay, meaning neuropathy. Then second is vitamin B12 deficiency is very common in these patients, because these patients take metformin. Okay, that should be excluded. Peripheral artery disease should also get excluded. Okay, so vascular claudication should be differentiated from neurogenic claudication due to diabetes mellitus. And then chronic inflammatory demyelinating polyneuropathy or motor neuron disease should also be differentiated, particularly in those patients who are having diabetic amyotrophy. And peripheral arterial disease should be differentiated in patients who are having claudication like pain. Okay, meaning if they have pain in the calf or foot, and the pain is lancinating type of pain. Okay, pain in the foot should be differentiated from peripheral artery disease. Okay, then hypothyroidism, particularly if the patient is having compressive neuropathies like carpal tunnel syndrome, tarsal tunnel syndrome. Okay, so hypothyroidism, thyroid should be ruled out. Alcohol induced neuropathy, okay, this should also be differentiated. So this is the neuropathy. 5 things should be differentiated. So B12 deficiency is very important. B12 deficiency should be differentiated. Thyroid should be ruled out. Alcohol should be ruled out. Chronic inflammatory demyelinating polyneuropathy should be, CIDP should be ruled out. And very important, peripheral arterial disease, vascular claudication should be ruled out. Okay, now how we should rule it? Coming to one by one we will discuss. So DSPN typically presents as symmetric burning pain, paresthesia, sensory loss in a glove and stocking pattern, Pain typically worsens at night and is relieved by walking. So this is unlikely. This is just opposite to your vascular claudication, where the pain is worsened by walking, and it will relieved by getting if the patient sleeps. Okay. Diagnostic important point are chronic. There will be chronic history of hyperglycemia. Clinical examination, we will there will be presence of loss of protective sensation that can be known by 10-gram monofilament test or 128 Hz tuning fork, where there is loss of vibration sensation. Confirmatory testing, B12 should be excluded. Okay. Vitamin B12 deficiency. So the dorsal column, there will be involvement of dorsal column basically here, and there will be proprioception loss here. Okay, proprioception loss. Upper motor neuron signs will be there, like hyperreflexia, reflexes will be exaggerated, and Babinski sign will be positive, and patient will have positive Romberg signs also. Romberg signs. Okay, because there is loss of proprioception. So symmetric distal paresthesia, sensory ataxia, okay, and motor weakness. Symmetric distal paresthesia, sensory ataxia, and motor weakness. Prominent dorsal column involvement, proprioception loss, and upper motor neuron signs, hyperreflexia and Babinski sign. Strongly associated with long-term metformin use. So serum B12 level should be ordered, and in CBC you can see microcytosis, megaloblastic anemia, and okay, that is important thing. Then in peripheral artery disease, there will be pain in the lower extremities, cold skin, pale and cyanotic feet, absent pedal pulses. Pain is provoked by exercise and relieved by rest, that is claudication. Bone structure is normal. Gangrene is more common than simple ulceration. So there will be pain with exertion which is relieved by rest, and absent or weak pulses. Okay. So differentiating features. Ankle brachial index should be performed. So calcified vessels can cause a false normal ABI more than 1.3. If such is the picture, then confirm it with CTA or MRA. And one more thing is toe brachial index, toe brachial TBI. In patients who are elderly and where the vessels are calcified and you are getting ABI more than 1.3, you can have TBI, okay, or you can go for CTA or MRA. Okay, that's the points in PAD. Then in CIDP, there will be motor weakness more than the sensory deficits. Motor weakness more than sensory, and there will be diffuse hyporeflexia. Diffuse hyporeflexia. There will be progressive symmetric proximal and distal muscle weakness with diffuse hyporeflexia. Motor weakness is greater than the sensory deficits. Rapid onset and asymmetric features. So here you do EMG and NCS. Okay. So this is motor neuron disease, actually rare disorder, but it is there actually. Hypothyroidism. So differentiating point, there will be delayed relaxation phase of deep tendon reflexes and dry thickened skin. Generalized paresthesias, muscle cramps, cold intolerance, weight gain, bradycardia, all this will be there. Delayed relaxation phase of deep tendon reflexes, dry thickened skin. Okay. TFT should be ordered. Alcohol, there will be painful burning feet and gait instability. Painful burning paresthesias in the feet, often with gait instability. Direct neurotoxic effect combined with nutritional deficiency, particularly thiamine. So there will be social history of alcohol intake. Thiamine levels should be ordered. Normal glycemic markers in these patients. So actually this part of our diagnostic differential diagnosis is the very important part, I think so. This one, because this part, this helps in differentiating different features, like, so DSPN, there will be chronic history of hypoglycemia, and you will do 10-gram monofilament test. Okay. Vitamin B12 deficiency, the dorsal column will be affected and proprioception is lost, so there will be sensory ataxia, and Rombergson will be positive, and because there will be upper motor neuron signs, and this is vascular claudication in patients with classical, and this is in patients with motor neuron disease, where you will have reflexes less, motor weaknesses will be more, and sensitivity. So you should check sensations, you should check power of the muscles, you should check power of the muscles, and you should check pulses of the patient. Reflexes also you should be checked. Delayed relaxation phase and dry thickening, this is the feature of hypothyroidism. painful burning in feet, gait instability, alcoholic patients. Okay, I think that is enough for now. Thank you.